Hello, I'm Mick Raich. I'm the president of Vachette Pathology and Stark Medical Auditing. I want to talk to you about some of the things we're seeing lately that are taking place. Interesting stuff. Let's start off with COVID, shall we? A lot of comments on that, a lot of issues on that. Medicare just came out and said as of January 1st, they're going to adjust the payment for COVID for high throughput tests to be $100 if you can get the results in 2 days. And if you can't get the results in 2 days, it's going to be $75. So now we have a payment-sensitive turnaround time? Interesting. Will this force labs to do it quicker? Hopefully. But on the other side, 6 of the National Lab Associations got together and sent a letter out to Congress saying, you know, we're struggling to get everything we need. For example, one regional lab reports allocation from a manufacturer for enough supplies reagents for 500 tests per day. That's what they could get, even though they could perform 3,000 tests per day. So they send this letter to the White House task force to say, hey, you want us to do it faster, you want us to do it accurate, but we don't have everything we need to do it. Interesting. You can see a couple things colliding here. Next thing, we got to remember the public health emergency was extended, but that doesn't mean free COVID tests for everybody. Please understand that Medicare came out and said we'll only cover one COVID test for you, and it has to cover, they'll give you one without a physician order, but after that, if you need one 2 months later or a month later, you're going to have to pay for it, okay? So you can't just randomly pull up to CVS and get a COVID test without a physician order. I think you're allowed one, but after that, all bets are off. So be smart. Work with your physician on that. The public health emergency now is going into January, so that's a good thing. That'll provide better coverage for COVID testing going forward. A couple other things. We're still seeing the downfall from billing on the COVID side. At Vachette and Stark, we spend a lot of our time auditing medical billing. We're not a medical billing company. We audit these billing claims. And for example, we have a perfect example we put on our website this week of someone who has a $2,000 procedure that was just written off for timely filing. Why? Well, probably the biller didn't have people there to file the bill correctly, and that's what happened, is the bill gets written off. We're seeing this over and over and over again, and it's frustrating. It's not a good thing. So let's focus hard on that and see where we can go with that. Excuse me 1 second. I bet we're all working out of our home, huh? We all got cats and dogs and kids and stuff. The good news is my cat's not here in my lap, although he is a fun cat. Iced tea, highly recommend it. Let me carry on. Surprise billing. Boy, this is not a fun thing. Recently, the Michigan legislature passed a law that said would require healthcare providers to inform patients in advance of a scheduled procedure where their health care insurer may not cover all the medical services, and that they can request care from an in-network provider. The notice must also inform the patient that a non-participating provider must provide them a good faith estimate of the cost of health care services to be provided. This ties into the transparency thing that the Trump administration is pushing. They want to know what's the cost of your test. Remember, the hospitals have to come out and list the cost of their tests. And they have to have, there's a $100,000 fine if they don't do this. Again, it's a big push on transparency. And surprise billing is designed to prevent a patient from getting a bill from an out-of-network provider that might be more than they can afford. But let's be honest, the current Affordable Care Act, and most people have insurance now with coverages that's, you know, $500, $600 to $700 a month with a $7,000 deductible. You know, you can actually argue those people with $7,000 deductibles don't have insurance. I mean, if you're making, you know, $50,000 and after taxes you got to pay $7,000 for your health care for a year, that's devastating. That's basically not insurance. That's a pain. The one thing it does say, in the emergency situation, an out-of-network provider would have to accept payment. That's the mean amount within the region that insurance pays for in-network provider, or accept 150% of Medicare pays for a medical service, whichever is greater. Patients will still have to pay their customer co-pays and deductibles. Interesting stuff here because, again, 150% of Medicare, I know a lot of providers think that's a good number. They'd be happy to pay that. But when they start looking at what's the median payment for that region, well, who's going to determine that? And it says here, it has the median amount for the health insurer pays. So I go to, let's say I have Blue Cross, and I'm go to the ER, but I'm, I'm I don't have insurance. I'm on a network. Blue Cross in that case, the health insurance in that cover in that area might pay 100% of Medicare, 50% of Medicare. What we struggle here is that the payers could arbitrarily drive down what their median rate is, and therefore make it harder on providers. Again, simple thing here. It says whatever is greater, get a contract at 150% of Medicare and you're going to be okay. You have to have that leverage to negotiate that contract, and that'll help you move forward there. That's what they're saying. And this is just the Michigan surprise billing law. Many states are going to pass this. I know New York already did it. I know the Trump administration is pushing for a national surprise billing. That's going to be real interesting when that comes out. It could make negotiating 10 times harder than it currently is. And lastly, the concept of where we're at after COVID comes up often in discussions, and I would argue that things are never going to go back to where they were. Let's be honest. Businesses change with the environment around them, and we've forced a lot of businesses now to, hey, how do we work from home? And a lot of billing companies I see have fired hundreds of people, and they're just not bringing them back. They figured out, hey, we can make as much money as we want going forward without these people. The problem is that your billing might be not done as well. There might be 3 or 4%, 5% that's left on the table. We see that as frustrating. But when we look at this, we also look at healthcare outcomes. I mean, there's some studies out there now that say there's a lot more stage 4 cancers being discovered because they were missed in April and May. We work with a lot of pathology groups, and some of my pathologists are saying, yeah, we're seeing really serious stuff that just was missed, just wasn't done. Heck, there's reports of people not going to chemo because of COVID. So this general fear of this overall national emergency has probably caused a lot more death than actually attributable to the probable deaths from COVID already. So if you die of stage 4 cancer and you have COVID, you die of COVID. We all know how that's being counted. What won't be counted is the people that die of cancer next spring because it was missed last spring and they don't have COVID. That's going to be the real tragedy here. That and how the environment changed and how businesses have changed going forward. We're working with a lot of RCM providers, a lot of big labs, a lot of big hospitals that do their own billing. And we're actually working with them now in process. We spend a lot of time on looking at your RCM process and scoring that and saying, here's what you're good at, here's what you're not good at. Now that, for example, if you laid off 50 people, how do you track your metrics going forward? We spend a lot of time on that kind of stuff. Well, thank you for taking a minute to chat with me. I'm Mick Raich. I'm the president of both Vachette Pathology and Stark Medical Auditing, and I thank you for taking time to listen, and enjoy your iced tea.